Well, hello and good morning, and welcome to our Ontario Network of CAPC and CPNP Projects 2023 online conference. My name is Sydney Bell. I'm the network program lead. Really happy to have you here, and I'm very excited to introduce our next speaker, our keynote speaker, Heather Cameron. Heather is the Executive Director of the British Columbia Association of Pregnancy Outreach Programs. And she is here today to talk to us about connecting with pregnant, postpartum, and newly parenting people who use substances. And we're just very glad to have you here with us, Heather. Thank you so much for joining us, and we look forward to what you have to say.
Thanks so much, Sydney. And I, of course, appreciate the land acknowledgement you did this morning, and also the videos that you had this morning. I was just thinking that toy bus is so cool, living here in BC and having so many small communities. I would love to talk more about that one day. I just thought those videos were so cute. So thank you so much. Thanks so much for having me. As Sydney said, my name is Heather Cameron. I'm the Executive Director of BC APOP, which I know some of you are familiar with. Today, my presentation, I'm going to be talking about perinatal substance use. I'm going to integrate some best practices, but also some lived experience for you. So I really appreciate when I'm sharing a piece of me. We'll try to do some interactive stuff, but I also really appreciate cameras on if you're able to. And it's really just for a give and take relationship and exchange when we're on a virtual platform, because I really feed off of your energy. So your smiles, your nods, Kim's nodding, that's what makes me feel comfortable when I'm sharing a piece of me. So thank you. And I also understand if you're doing something else and you can't, that's totally cool, but I love that I can see some faces. So thank you. I would like to start with our land acknowledgement this morning. So I'd like to begin by acknowledging the Indigenous peoples of all of the lands that we are on today. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we are and can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. Please join me in a moment of reflection. Thank you. So I always like to do a tiny bit of content awareness, especially on this topic that can be really emotionally driven. We'll talk about some sensitive things, some emotionally driven things. And just like me, I have my own history, my own story. You also have your own history and your own story. Often when I do trainings like this in person and we get together and we do a small group for 2 days, we really get to know the room and who's in that room. In this virtual context, and being a keynote, we won't have the chance to engage with one another. I won't be able to hear your story. So I just really want to recognize that sometimes the content I share brings up feelings, whether you are a person with lived experience yourself, you're a grandmother of a baby who's been exposed to substances, your sister maybe is someone who struggles with substance use, whatever that looks like in your life, it's totally, absolutely healthy and okay if you need to step away from my presentation, and I won't be offended at all. Of course, if you're struggling further, I just ask that you reach out to Sydney, and I'm sure Sydney will provide you with mental health resources to access to. But I just want to acknowledge that sometimes self-care means we need to step away from presentations, and I've done that myself in my nursing career as well. So please take care of you. The next thing we'll talk about, I always like to talk about where information comes from, how we decide to do things, that perinatal substance use is a really great area. But I also want to acknowledge right from the beginning that it's okay if you don't agree with the approaches that are presented, with the ideas that are presented, or my comfort level with perinatal substance use. So when we do trainings, when we do events like this, really our goal at BCA POP is to increase comfort levels. So not to make everyone an expert, but really to create an ally for people who use substances and to increase comfort levels of having those discussions and providing that practice. What that means is that everything I say might not fit for you, and that's totally okay. You can leave that behind and you can take what fits for you at this point in your practice, in your career, in your life. And I think that's an important ongoing trend, specifically in perinatal substance use, because it will never be a black and white topic, as we'll talk a little bit more about. I am a mom, so I will take any chance to show you pictures of my children, and this is the chance I'm taking. So a little bit more about me. We talked about I'm the current ED, so I've been the ED for BCA POP since 2018. It's getting a little bit, I think we're going into year 5 now. My history as a nurse is I have a perinatal specialty and have worked in labor and delivery and maternity here in Kamloops, also known as the traditional Secwepemc territory. I've also worked in detox, so withdrawal management. That's a medical unit here in Kamloops, supporting people to detox from different substances, both males, females, and gender diverse people. And I only graduated in 2016, so I went back a little bit later in life, and we'll talk about why. Went on to perinatal specialty, and previous to that, I was the co-founder and executive director of Family Tree Family Center and Mothers for Recovery, which is a peer-driven organization here in Kamloops that's still running today. And that went back to 2005, so many moons ago. And then first and foremost, I'm a mom. So these are my 2 girls, Sadie and Celine. They are 17 and 18. One just graduated, as you can see. The other one is graduating this year. Sadie there, who graduated, is in nursing, and Celine will be heading off to the same university in September. But I'm also a woman with lived experience. So during both of my pregnancies, I used substances. The location I was in specifically with Sadie, who's my shorter one, my firstborn, was the downtown east side of Vancouver. And I've accessed organizations such as Sheway and First Square, which we'll talk maybe a little bit about today if we have time. But really accessing gold standard care in an area of Canada, sometimes known as the poorest postal code, still engaged in sex trade, and using all the way through my pregnancy and really accessing those true outreach services. So my passion for perinatal substance use comes from, I'm a crier too, comes from an experience of being supported in the best way possible at a time in my life when I was not ready to abstain from using substances during pregnancy. So our idea at BCA POP, our little dream, is to make sure that no matter where you live in Canada, where you live in BC, that you have access to the same gold standard care, even if you don't have a Sheway, don't have a First Square, which are really specialized organizations. That is a bit about me. And that is where my passion comes from and why I get so attached to this work. And there's been times in my life when I thought, even when I went into nursing school, like, oh, maybe I'll do something different. And I always come back to doing this. So I think it's what I'm meant to do now. I'm just going to accept that this is what I do. So a little bit of an overview of our project at BCA POP. Our perinatal substance use project began in 2019. So within a year of being hired, we were funded by PHSA, our provincial health authority, to do a project specifically around perinatal substance use. The first year that we did this project, we created a handbook, which was just updated actually in January, and you have the link to our store. And if you go to the bottom of our store, there's free PDFs, including the perinatal substance use handbook. So you can just download that and print that without purchasing anything, as well as some other resources that are free there too. So our first project was to create a handbook, of which the content that we're going to talk about today is really based on. The beautiful thing about that handbook in this presentation is if I show any content, you'll see on the slide there's a page number. Everything we talk about is absolutely in that handbook. So please feel free not to write any notes at all. Because of course you can go back and review anytime you want to. When that handbook was created and our full, we did 2.25 day training at that time. Now we've got it down to about 2 days. Was created, we sponsored about, I would say, 600 perinatal professionals and helping peers throughout the province to attend that training. We had the funding to do that. So we were able to travel around and do that in person before the pandemic hit, which was beautiful. Since then, thousands and thousands and thousands of people have done our PSU training, which we're really, really grateful for. Of course, the intention just being increasing comfort levels of perinatal professionals and helping peers. We also engaged with CPNP programs in BC, did a needs assessment, really looked at what kind of resources people were looking for. That resulted in the training, the handbook, the tool cards we'll maybe get to today, and then a perinatal substance use webpage. And that's the other link I put into the chat. So that webpage is updated at least quarterly. It's not an overwhelming list. It's a great starting place if you're looking for Canadian resources specific to substances or best practices. I would say it's our #1 webpage through analytics that we have at BCAPOP that's visited, free to use. Please engage with it whenever you feel that you need a starting place. And then later on in 2020, so right before the pandemic, we were also funded by the same organization to start a pilot project. So just like I talked about, if I'm pregnant, I'm accessing care in the downtown east side. It's very specialized care. It's gold standard. Our dream to expand that care elsewhere without those specialized organizations really came true when we were funded as an organization to do a pilot project in 10 communities through BC. So we have 10 in-reach workers who are social workers or registered nurses who try to emulate that same care in a community context, piloted out of a pregnancy outreach program and working in collaboration with an acute care center, so a hospital. And they have a caseload of only 4 to 7 pregnant participants at any given time and do really, really intensive, great work with each of those families. Hi, Marianne. How nice to see a familiar face. You just popped up on my screen. Welcome. So we've been given this really, really great opportunity and they're doing some really beautiful things. They're going into their 4th year of funding, which is really exciting for us because it was supposed to be a 12-month pilot project. We do have a handbook in development for that. That may turn into a training as well for other organizations to just implement those same approaches to learn from what those 10 pilot projects created, which is super exciting. So definitely for BCAPOP, I would say right now, just because of our funding structure and what we're funded to do, about 75% of our work is very specific to perinatal substance use in British Columbia. I'm going backwards. Any content we talk about today, I always love to talk about who was part of developing it, where does information come from, who's making those decisions. I think it's also an important, as I'm sure you agree, to have conversations with participants in our programs about how do we decide that information is credible? How do we decide where we're getting information from, especially in a world full of technology? So any of the information we talk about or that you'll see in that handbook that I've given you the link to involved this entire committee. I wrote the skeleton for sure, but every single person had an area that they reviewed based on their specialty. So one person we had was Sarah Payne, who's worked for Sheway in Vancouver for 20 years. She's now retired. I pulled her out of retirement, brings tons of experience, also has a lot of experience working in the United States with birthing people who are birthing during incarceration in prison. So she brought a lot to the table and a lot to that handbook. Nancy Poole, many people are familiar with the name, Dr. Nancy Poole. She works for the Center of Excellence for Women's Health and is the lead researcher there, has her whole life spent time specifically focused on women, girls, and alcohol use, and of course does lots around substance use as well. As we delve into breastfeeding, we wanted to make sure we had, of course, lactation consultants. So Sue Clarkson is one of our CPNP coordinators here in Fernie. She's an RN, a lactation consultant. She brought a lot to the table, especially around not overcomplicating things. So reminding us of who the audience is and that we have to remember that many people are in a starting place regardless of their educational background when it comes to perinatal substance use. Katie Graham used to be our contact for PHAC. She was a really, really key person in the start of this project, and she brought, of course, that lens from working with CPNP projects. Dana Clifford is the clinical supervisor and still is the clinical supervisor at Sheway. She's a registered clinical counselor as well. Erin Fulton was another RN and lactation consultant. She runs one of the nurse family partnerships here in BC. I'm not sure if you have that in Ontario, but it's an intensive public health program. Stacey Boone is an education leader. Sarah Hine unfortunately passed away during our committee time together, and she was a really important knowledge keeper for us from the Carrier-Secani area in BC. And then Megan Brister was on our board. So as you can tell, we had a lot of different people contributing, a lot of different people reviewing, and Nancy always reminds me we need everyone at the table. So people with lived experience, researchers, policymakers, frontline workers, and that's how we created that committee to make sure we were well-rounded. Of course, getting feedback from some of the CPNPs along the way. So one activity, and I apologize, Sydney, I didn't know you had the special board and I don't know how to use it, so we're gonna skip it. So we're just gonna use chat for this.
Oh, yeah, totally. So
when I teach pregnancy outreach programs in CPNP and we have really good conversations about intake forms, one of the main things we always talk about is strengths-based approaches. So we always talk about, and you'll notice in our forms, if you ever see them for HCPP, our Healthy Care Pregnancy Program, the first thing we always ask participants is what's going well for you. So the idea is we always need to be doing more of what's working instead of focusing on doing less of what's not working. So the first thing I'm going to ask you to practice this is what is going well within your programs around supporting pregnant people using substances. And if you can just throw it into the chat, that would be great. What is going well for you in your CPNP programs around supporting pregnant people using substances?
Yeah, there's lots of, I don't know if you're seeing the chat. Would you like me to read out?
I'm good.
Comments?
I can see it. I'm good.
Okay.
Non-judgmental attitude, staff are non-judgmental. Referring to other programs, sincere interest in how they are doing. I love that one. Authenticity. Community partnerships. Meeting them where they're at. I love that. We might talk about matching professional goals to participant goals. Knowledge on how to ask about substances. And having standard questions. So I love that. We call it, thank you for that. We call it universal education. When we talk about making sure that everything we do with every single family, no matter what our assumptions are. So not just talking about breastfeeding and harm reduction with people who we know use substances, talking about that with every single family. Not just talking about substance use during pregnancy with people who have self-disclosed or we suspect are using substances, making sure we talk about it with every single family. And I really practiced this when I worked in the hospital and maternity. So we do discharge teaching. I talk about substance use and breastfeeding with every single family. And people would be like, oh, no. Like, I don't use those kinds of substances immediately, which is fine, whatever. I just got on shift. You don't know me. And I would be like, oh, but I go over this with every family because you are the best transmitter of education. So peers are the most important people for many ages and stages in our lives, including parenthood. So how many times do you hear someone who's like, oh, my aunt told me this, or my grandma told me this, or my friend told me this? Knowing that, I want to make sure that we're sharing this information with every single family because they're the key influencers. Suddenly, families are more open to hearing information that's evidence-based when they realize that my intention is that they also can be the sharers of information, if that makes sense. It's also super interesting that once they're open to the conversation and I start going down the substances, it's amazing who into the conversation will be like, well, once in a while we do a couple lines of cocaine. Like maybe this is more useful than I initially told you. So it's really, really great to start building that rapport. I loved what someone said about making sure we just do this with every single family. I love that. Really useful. The next question I'm going to ask for the chat is, what resources do we need to do better? So what do you feel in your own professional practice or as a helping peer, what do you feel that you need to do better around supporting people who are pregnant and using substances? So I can see talk about it more, knowing who and where the resources are, having private spaces. That's a good one. Thank you, Marianne. Find a way to get what they think they need. Education, having appropriate resources. Funding, always the ongoing discussion these days for sure. Awesome. So I think it's just always good to reflect on, I love that funding was brought up for sure. That's always an issue. I would say our intention when we go in to do any sort of training, and I do a lot of acute care staff too. So for example, I'll do groups of health authorities. I'll have 25 acute care nurses that only work in LDR and maternity. And we specifically talk about what can we change tomorrow without any structure or any system changing, because that tends to be the most difficult thing when people start saying things like, we don't have funding, there's no beds for treatment, there's wait lists for detox, we don't have the staffing complement, we're short staffed, but there are still a million other things that we can change along the way. And that's really our intention, is for you to walk away and be able to change and implement practice changes tomorrow, which always excites me, because it just realizes the actual positive power you have as a perinatal professional to change lives in a really positive way, and not even necessarily in a way where parents and babies are going home together, because that's not always the success. Specifically, if we talk about pregnancy, we can affect that pregnancy journey and subsequent pregnancies, even if that pregnant person doesn't take that baby home. And we can still have a positive impact. We can still identify successes, and we'll talk about a little bit what that can look like. So thank you for participating. That's awesome. So looking at roles of professionals and helping peers across Canada. So really recognizing that we all come together today, and any perinatal professional has a variety of background and experiences. And this can lead to implicit and explicit bias, of course. We all have experiences with our family, friends, within our own life story, with our children, that are going to influence how we practice today. And really being aware and being able to catch ourselves when perhaps we are doing more harm than good is a really important skill to have. So I always want to identify that it's absolutely okay to self-disclose if we're not comfortable working with perinatal substance use, and if we feel feelings like anger or resentment, or I can't think of the third word I would usually say now. But if we have negative feelings that is going to impact our practice supporting a pregnant person using substances, it's totally okay, if you can, to pass it off to someone else if you feel that you're going to do more harm than good. That's a really important skill to have as a professional in any area we work in. The next key piece is self-evaluation and reflection to identify that bias and judgment. So some of us, judgments is spelled wrong. Some of us can work through our bias and judgments, and be able to do work by going to trainings, by going to workshops, by having conversations. So perinatal substance use is not something that I would say we change the culture of it through doing modules. I don't know if you've ever worked in a health authority, but I have, and everything we learn is modules. And we do them on night shift, and we're talking while we do them, and we just get through them to do them because they're required. So perinatal substance use is really a place where we need to have an opportunity to discuss what our fears are, what we're uncomfortable with. We want to be able to ask questions to someone who's safe, who's going to answer them in a safe place, which usually is not our participant. So I love when we do, and Sydney, I know we're doing a 2-day workshop really soon with some of your projects. In that training, we'll have opportunity to specifically have an opening roundtable, specific questions, dialogue back and forth, and a closing roundtable. And that's where we often get to a lot of the root bias judgments that we don't even know we're carrying with us, which is always so exciting for me, because people tend to have really have those aha moments, like, I didn't think about it that way. And I'm the same way on other topics, right? There's all sorts of things that all of us are on a lifelong journey for, and that skill to be able to be like, oh, I never thought about it that way, or I never understood why people did that. Now it makes sense to me. I love those moments. Also recognizing that as a perinatal professional, we can often be the early point of contact. The other people who tend to be the early point of contact that we don't see enough engagement in workshops like this is your front desk person, your receptionist, whoever is the front face. So often if I tell my story, which I'm not going to do today because I don't do it on recordings, but sometimes I'll do a full story, which is about an hour and a half, and I'll pull best practice into personal experience. I talk about Sheway and the first time I went to Sheway. So Sheway is CPNP here in BC. It's in the downtown east side, which is an area that's heavily populated by people experiencing extreme poverty, homelessness, engaged in the sex trade, and using substances. And it's kind of a 24-hour around the clock area where people have access and are using substances out in the open 24 hours a day. So I had found out I was pregnant, and we can talk about where and when and why another day. But I went to Sheway because Sheway was the place to go. It was about 3 blocks away from my SRO hotel room. And one of my outreach workers had been like, you know, you got to go to Sheway. And my intention actually was to go and access a termination, because I had assumed with the amount of substances I was using, one of my assumptions, or one of the myths I had, was with the amount of substances and stimulants I was using, that this baby would be deformed. So I was trying to access an abortion. So I really talk about myth busting often. But when I walked into Sheway, Sheway's a 5-story building now. It used to be like a portable before my time. So this is 2003 now. Ron Abrahams was down there. Sarah was working there. Georgia was working there. These are people you may have seen over the years in other forums speaking. And I walk into Sheway, first thing is the receptionist, and Gio was sitting there. And I know Gio now for sure. I've known Gio for years. And the thing that Sheway does beautifully is they understand that Gio is the most important person in that organization, hands down. If Gio is not the welcoming, trauma-informed, harm reduction-based person that people need, people will not be engaging in that organization. It doesn't matter how great your doctor is. It doesn't matter how great your nurse is, your counselor, your food, your lunch, your donations. None of that matters if the front desk person is not almost your best trained person. And Gio was absolutely on point. So Gio has this gift. Sorry. Okay. Gio has a gift of treating every pregnant person like a pregnant person, regardless of how under the influence of substances you are. So if we think about people on the street who are doing, we call it Main and Hastings shuffle in this community, like that's what I would call it in my recovery community. People who are definitely, you know, they've been up for 6 days, 7 days, whatever that looks like. that was very much my experience as a person using substances, is I would be up for, 6, 7, 8 days at a time and visibly using substances. And Geo is the person who's like, hey, like, do you want to go through the donations and like pick out a sleeper? Like, hey, do you want to talk about like what you're going to name this baby? Like, oh, you just got to go upstairs and get checked by the doctor, and then I'm going to feed you some lunch, regardless of what current situation is. So if you wanted to identify as a person who was going to take a baby home, if you wanted to aim for parenting, Geo was going to treat you like a parent from day one, hands down, period, no judgment. Also, if you wanted to access things like terminations, adoption, whatever that looks like, she's also going to treat you however you identify in your parenting journey on that day at that time, because as we know, it can change over time too. I still have, sometimes I show up, but I still have the very first sleeper that Geo gave me. And I remember like throwing it over my shoulder and like going back onto the street to work the street. Like, I got the sleeper, I'm going to be a parent, but today I'm still using. And that always made me realize how much we should be engaging our frontline staff in trainings like this. So just kind of a take-home note. I digress on stories like that a lot, just so you know. We're going to get through about 5 slides. The next thing is an opportunity to assist early and on an ongoing basis. So role of professional has more positive power than we talk about, and we need to talk about it more. Often the conversations we'll have, which are really important conversations, is about power imbalance, especially when we're talking about Indigenous cultural safety, systematic racism, and when people feel like they've been treated poorly, which I definitely have been treated poorly as a pregnant person, but those aren't the examples I tend to use when I'm speaking or when I'm training. The examples I love to use is when I was treated so very well and what a difference that made in my life and how the stars aligned. So the opportunity you have, Sydney, can I assume everyone's a pregnancy outreach worker? I should have asked you that. Tina's saying no.
Yeah, no, I wouldn't
say
that, because we have lots of folks who do work for CPNP, and we also have lots of folks in CAPC programs. But of course, folks in CAPC programs are interacting with pregnant people as well.
Yes, so we're all frontline workers.
That's right. And there'll be managers and supervisors here as well. Okay. Everybody has that, generally that experience.
Awesome. Beautiful. So I always believe in talking about the power of positivity as well, and not just focusing on the power imbalance, because the power we have as professionals to contact early and absolutely influence people's lives is huge. And I think often professionals, let me say that a different way. I get really excited, for example, if I work on an LDR unit, I've worked here in Kamloops, I was a brand new nurse, so not experienced in managing labor. If that's what we're gonna call it in medical terms, managing a labor as an RN. Not experienced in that, but what I was experienced in on my unit was treating people who were using substances in best practice ways. So that was kind of my little area of the world, and the area where I had to have a shaky voice sometimes. The most exciting culture shift I ever saw in, let's say, the 2 years on LDR here in Kamloops was when extremely experienced nurses, experienced LDR nurses, I would start to come on shift and they would come up to me like, Heather, like, you'd be so impressed with what I did today. This is what I did. An example of that would be, I had one nurse, she actually called me after shift and she was like, Heather, I made sure that baby had skin to skin. And then breastfeeding was contraindicated. So I made sure that mom fed the baby the first bottle of formula, and she had never fed her previous babies. She had 5 previous babies and she fed this baby first. And then I made sure I pushed her outside for a cigarette. And then we came back and then I made sure that I pushed her and the baby down in a wheelchair to the NICU and that she placed the infant inside the bassinet instead of the ministry removing from her arms. This particular mom was did not have the intention to take this baby home. Ministry was definitely coming. She knew it, we knew it, and we ensured that this was the first time a baby wasn't removed out of her arms, that she placed it in the bassinet, and then the ministry took custody. So those differences for that person who was on birth number 6, all removed, were completely different. And if we think about the impacts, okay, you know, someone might say like, but the baby and the mom didn't go home together, so what does it actually matter? And what it actually matters is that every time we have a traumatic birth experience, we are more likely to replace that pregnancy by getting pregnant again. And we are more likely to try to recreate a situation that is not traumatic. I remember Sarah Payne once telling me, I told you she worked at Sheway. She was one of my caregivers when I was pregnant, and now is just a really good friend of mine or colleague. She told me when she was young, working in the prison system in the US, a pregnant person had come in and she was birthing, and they had handcuffed her to the bed, and that it was the most horrific experience she had ever had. And it was very like, it was such a good point, because it even happens today. I don't want to say shackled to beds, but it's so easy in a unit or in a program or in an organization to get on board with something that doesn't sit right with our values and to not feel strong enough to speak up about it. And I just remember her saying, I will never be part of another traumatic birth in my whole entire career. And I adopted that instantly. For me, that was like, right, that's exactly what kind of nurse I want to be. I will never be part of someone's traumatic birthing or pregnancy experience in my whole entire life. There will absolutely be people contributing to that, systems contributing to that, racism contributing to that. Sometimes I might contribute to it unknowingly or by mistake, but I will do my damnedest to contribute to a trauma-free pregnancy and birth experience. And I think that's, you know, when we go into practice and we talk about value-based practice, which I love talking about, it is so much easier to have self-compassion around, I don't need to be an expert. However, my values are a trauma-free pregnancy and birth experience, and that's going to guide me along the way and make sure that I find the resources I need to support this person well. And that feels good. So I just encourage you to really reflect on the positive power you have and the position you're in, and how to use that to impact people's lives and impact people's experience with pregnancy and with birthing, regardless of custody status. And then the importance of self-care. So super difficult work you have on any given day, experiencing and supporting people who are experiencing traumas, barriers to health and wellness, and obviously losses and things that happen that feel horrible and that we're hearing about. So there's lots of discussion about vicarious trauma. I know many of you will know about that, be familiar with how that works. What I love is that there's new research coming out. We're doing this research project. We just applied for our second year grant, specifically for our pregnancy outreach workers, and how they are relating and they are reacting and they are doing self-care in relation to hybrid programming as a result of the pandemic. So what we really wanted to focus on was our frontline staff for this research project, not our pregnant people, which is a really unique project. And one of the things that's coming out is that for some of us, and this rings true for me, for some of us, we actually become energized by hearing people's stories and walking shoulder to shoulder for them. And for me, and some of you might be like, oh, that feels good for me. For me, that rings so true in comparison to like, oh, I'm drugged down by people's, you know, traumas or experiences or barriers. Instead, for me, I'm energized by walking alongside someone, because I think I just naturally maybe carry some hope. That's very resilient hope for almost nearly any family I've ever worked with. I don't tend to lose hope. So I think that's exciting research that's going to come out, and I'm so excited to see how that plays out for CP&P programs, not only in BC, but across Canada, and what we can learn from that, especially with that self-reflection as a perinatal professional, because you would think if vicarious trauma is the main theme, that none of us would do this work, but we love this work. So why do we love this work, and why is this work energizing to us? So that's kind of exciting.
Heather, I just have to say, there's lots of love for you in the chat.
Oh, okay.
But I just love what Barb just posted, listening to you. She said vicarious resilience is what you're talking about in this research. So I thought that was kind of neat. I just wanted to point that out.
Should we look at anything else in the chat, Sydney? I've been ignoring it.
No, just,
or are we cool?
I think I'm not seeing questions, just people acknowledging this is important conversations, and you know, just that they're being affected by what you're sharing. So I'm not
we're good.
Any questions yet. I think we're good.
There are people dropping off and leaving. That's always everyone's fear, right? Like, oh, is everyone going to leave during my presentation? Awesome. Thanks, Sydney.
You're welcome.
All right. Language. Language is so important to me as a professional, and I don't know why I almost have a little bit of like OCD specifically around language and how impactful in a positive way language can be. And I've seen this play out not only in my own life with my children who are both exposed to substances, but in my professional life. And again, it's hard to be the shaky voice, right? It's hard to role model language. It's hard to change language as language changes, and it changes so fast, right? If you were to ask me 10 years ago, if I was doing writing about perinatal substance use, I would call it problematic substance use. And that was a very accepted term about 10 years ago, maybe even 15 years ago. I think I'm getting older really fast. Where now we would never use problematic substance use. We would just use substance use. So substance use is a great catch-all phrase, for example, versus addiction or substance use disorder, which is a medical diagnosis. I'm glad I don't have to use that because I'm not a doctor. So if I'm working frontline or I'm supporting my in-reach workers doing HCPP, we just use substance use. The great thing about using that term is there's no argument over it. So if I were to say to you, let's say you're my participant, oh, do you have problematic substance use or do you have addiction issues? I can tell you right now that when I was using substances, maybe sometimes I did not identify as an addiction. Because I thought I could quit when I wanted to. Problematic substance use, again, that it can create area for argument. It can create area for different perceptions mean different things. If we just talk about substance use, which really is a cornerstone of when we talk about substance use in pregnancy and substance use in breastfeeding, substance use has the least negative connotation possible. It's more neutral for sure. So if I use substances, whether that is nicotine, and I'll always go through all of these when I talk about pregnancy or breastfeeding. So I start with more socially acceptable ones, nicotine, I go to alcohol, I go to cannabis and THC, then I go to stimulants, which would be like our cocaine, our speed, even our ADHD drugs that are used non-prescription, maybe used in a self-medicated way. And then I go on to opioids. So those are, when we talk about substance use, we're including all 5 of those categories of substances. And that is a way to reduce the stigma of substances such as stimulants. Let's just talk about like crack cocaine or cocaine, and opioids, our fentanyl and our heroin. It is a way to reduce the stigma of those substances, because when we're talking about substances, now we're talking about all substances. It's a way to open more conversations with more families. It is also a way to engage with people and not require self-disclosure. So if you were to ever be hired to be an in-reach worker in our pilot project, we have worked so hard as a group to respect confidentiality, to respect consent, and to respect the right to not self-disclose. So I do not work for the ministry. I'm not a police officer. Therefore, if I'm a nurse and someone doesn't self-disclose that they're using substances, my view, my perception of that is they have a right to not self-disclose. Just because I am a nurse does not mean I have access to all of your information. You're human with the right to confidentiality and a right to privacy. So that really gets us over the conversation of like, you know, sometimes nurses will be like, or colleagues or frontline, but Heather, they lied to me. They didn't lie to you. They have a right to not self-disclose. When I do trainings for MCFD workers, we talk about that a little bit differently because they have a legal right to access of information, of course. But if I'm a frontline worker in any other context, I really respect the right to people's privacy. So that kind of loops us back to universal education. If we are talking about all 5 of these substances in pregnancy, in breast or chest feeding, with every single family, we're not missing anyone because we're not depending on self-disclosure in order for us to have the conversation. I'm just having it with every single person. I'm really reducing stigma. I'm sharing information that people can share with other people. I'm reducing and busting myths out there. I have, I should show you. I might cry. There was this great street nurse who did my pregnancy test with my second daughter. I have this stack of books here, and some of them are called From Witches to Crack Mums and Criminalizing Women and the Highs and Lows. These are like 25-year-old books, and there was this street nurse here in town, and she was just lovely. She was so on point. She ended up passing away of breast cancer. I would say I was about 25 years old, so I probably wasn't even abstinent yet. I had had my second daughter, and these were her books, and someone gifted them to me last year. They were at the university until last year, and like it's still got all of her tags and all of her notes. But when we look at that, like From Witches to Crack Moms, and if you look at history, I did this English paper once on, we look back in time at like the 1980s, and like crack babies would be a normal news article, right? These crack babies are being born, and how much stigma has followed, specifically the substance categories of stimulants and opioids. That's what led to things like me thinking I needed an abortion because I assumed the baby would be deformed. Sadie has all of her arms and legs, not deformed at all, not even close to being deformed, right? So that's really, the stigma has really followed those 2 substances. We need to work really, really hard, and it'll take probably just as long. So if we look 40 years back, that stigma has been following those 2 substance categories. It'll probably take 40 more years to reduce the stigma around those categories. But I try really, really hard every day to talk about substance in a normal way. And I love, Nancy Poole has said to me before, you know, substance use is a normal part of pregnancy. Because you could even go so far as to say, well, caffeine is a substance. Substance use, it doesn't mean it's good, it doesn't mean it's bad, but it is a normal part of pregnancy life in Canada. Substance use is a normal part, and it's something that is common and something we need to address on a daily basis, and not just specific for a small population. So going back to person first language, I'm sure you've had a chance to look at neutral connotation versus negative. So really the idea behind person first language that feels good once you start talking that way is that we always want to put the person first. So if I'm talking about a pregnant person who's using substances, I'm never talking about an addicted pregnant person. I'm not even talking about a substance using pregnant person or pregnant woman. I'm talking about a pregnant person first who uses substances, because that may change. That would be the same for anyone. We don't talk about, let's say, diabetic patients as like, that's a diabetic man, right? Like, we really want to make sure that we're putting people first and putting their issue, their diagnosis, whatever their barrier is, second. So same when it comes to babies. When we talk about babies, I've heard a lot, and I'm sure you've heard, like, oh, that's an addicted baby. The truth is we can't even have addicted babies. So the meaning of addiction, if we talk about diagnosis terms, and, you know, when I'm talking to physicians, mental health professionals, psychiatrists, and they're talking about addiction and the process of addiction, and they need to use those terms. Addiction is really about continuing to access your drug at any means necessary, regardless of consequences. When babies come out and they're exposed to substances, they are not doing that. Therefore, it is impossible to be an addicted baby. That being said, we can be a baby exposed to substances. I'll also hear to NICUs like, oh, that's my NAS baby. A nurse talking to another nurse about like their baby in the corner. The problem with this, of course, is if we were to say, well, I only use that with other nurses, is that I can tell you for sure, in our programs, in our organizations, in our acute care centers, every conversation we're having is being heard by others. So when I first had Sadie, my first daughter, I was in a Kamloops hospital. I didn't deliver in Vancouver. I was here for 30 days before Sadie was born. I was 30 days abstinent when she was born. I was so proud of this baby, and I had so much First Square. So First Square in Vancouver, you live there. It's a hospital ward you live in. I was so lucky. It opened in 2003, and I went in 2003. I was so lucky to have it. And I had been so surrounded by this best practice of knowing, like, we do kangaroo care, we breastfeed, we care for our own babies, we room in even if they need help. Like, I was so used to that because I had lived in First Square for about 3 or 4 months on and off, that's what I expected when I delivered in Kamloops, never having a baby before. And that was not the case in Kamloops. I won't tell the full story, but one of the things that occurred for me is I was so proud of this baby. She was tiny, 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 5 pounds, 2 ounces, likely almost full term. We don't have proper dates for her. But she, you know, proper lungs, all those good things. So she eventually was allowed to room in with me. And she breastfed so well. No one ever helped me. She latched on. I had done all this work in FER to, like, yes, breast is best. Like, if you want to breastfeed, you should breastfeed. Mom is the first line of intervention. Any baby who's exposed to substances. I knew all of that because I was surrounded by it for months. So she was feeding. I was so proud of her. A nursing instructor came in and was like, oh, can we do an assessment of your baby with these nursing students? And I was like, sure. Like, look at my beautiful baby. She's adorable. And her name's Sadie. And they went in the hallway and they were like, okay, so this is an addicted baby. This is what an addicted baby, and I could hear them. Like, they didn't even go far. I could hear them. And I just remember being crushed, right? Like, I wanted my baby back instantly, and I wasn't strong enough to go get it because I was only like 21 years old at the time. And so just being really, really aware that wherever we use language, we are role modeling to our colleagues, we're role modeling to students who are awesome at language. At least my nursing students these days are just so much more advanced than I am, and I learned so much from them. But our families can hear us and people can hear us, and it really shapes the way we work when we're using negative connotation language. Person engaged in sex trade is usually an important one for me to point out too, instead of a prostitute or hooker, of course, because being engaged in a sex trade, the same as being engaged in office work, can change over time. So just making sure we're always putting people first. Takes a little bit of time to get it and to do it naturally, but I promise that it comes naturally, and that it's also okay to make mistakes. After we learn better, we know better, we try better. It's okay to make mistakes along the way, just correct ourselves and move on. And that would be the same with gender inclusive language and pronouns, right? So if we make the mistake with someone's pronouns, or we make the mistake with someone's gender after they've identified their gender, it's really important to apologize, make sure it doesn't happen again, and move on, instead of turn into this victim role of, I'm so sorry, I can't believe I did that. Oh my God, please take my apology. I've seen it happen lots, and it's kind of flipping the script and putting the person who we've offended to see us as the victim of our own language. So really flipping it back, apologizing in a professional manner, and just ensuring it doesn't happen again is best practice around making mistakes around language. And that really empowers us too, to not live in a really guilty way. So people will tend to feel really guilty when we're trying to change language and they don't get it instantly. Totally normal, totally natural, but just respond to it in a really professional way.
Heather, I just want to pop in just because.
Good, because I can't breathe, Sydney.
Again, thank you. Thank you. And I will acknowledge, going through your list there, the word clean is popping out at me. And I'm pretty sure that has remained in my vocabulary, right? So this is a really good learning for me. And I just wanted to acknowledge that, because the moment I see it on your list, I go, oh, well, oh, yes, that makes sense. And so
right, because the opposite of clean is what?
Exactly.
Dirty.
Exactly. Yeah.
Right.
Yeah.
So what's interesting about that, and you'll hear if you ever hear my full story. So I think it's important to recognize that participants have identified clean as a term that has negative connotation for them. People have identified that. So that's best practice. That being, so I'll never use the term clean. Like I use abstinence naturally when I'm working, when I'm in my professional role. That being said, in my own recovery community, so I'm a through and through 12-stepper. It's how I got abstinent. In my own recovery community, clean is a very accepted term and very normal. So if you ever hear my personal story, I'll refer to myself as clean. I've been clean, it'll be 16 years this summer. 16 years this summer. So I refer to myself in my own personal story that way, but in a professional role, I would never use that term. So that was a really good one to point out, Sydney, because I had never thought about that either, because it's what I refer to myself like. And I remember when I learned that and being like, oh, I never thought about it that way, right? It's just another example of just being on that lifelong journey.
Thank you.
I want to look at the time because I know I can, yeah. I know I can take off on tangents, but that's my style of presenting. All right, this pertains to CPNPs and CAPCs so well. It's a super simple slide, but it's really important. So best practices specifically around people using substances. Let's even talk about families still using substances or a history of substance use. That one-to-one support piece that you provide in addition to groups. So I'm sure many of us realize that if someone is actively using, really struggling, facing many barriers, sometimes group support is not the most appropriate at that time. Sometimes it is, depending on the group, but sometimes it's not. And just really checking in. And I think this same check-in comes more naturally when we talk about someone who's lost a baby to a perinatal loss. Instantly, everyone's like, oh, group's probably not going to feel good. I need to check in with that person. So we need to be doing the same when maybe we have people relapsing, using, losing custody of a baby. What does that look like? And within our program, how do we provide one-to-one support? And I know here in BC, you can correct me if this is wrong for you, but I feel like from working in a POP or doing a practicum, at least in a POP, and being very connected to my local POP professionally, I feel like there was so much pressure for so many years to do group work, and that they really lost that skill and that authenticity of being able to walk out the door and engage with a pregnant person. So I'm not sure what it looks like in your program, but I always come back to that conversation of what are we doing for the small population that we have, whether it's people experiencing mental health, postpartum depression, psychosis, substance use, violence, I don't care what the barrier is. How are we ensuring that we can still do one-to-one for the people that one-to-one is appropriate for? And that's real healthy care pregnancy program. Like that's really the basis of that idea of that program, is that some of the population who are not well connected, who have such a short span in time to make all these changes, they need one-to-one support. It's not optional. That's what we need to do good work. And I know many people feel that way working in CPNPs and CAPCs, but sometimes there's pressure from above, funders, organizations, EDs, to do more group work because those numbers look better. However, it tends to be the population who could benefit more from the impact of our work, who needs that one-to-one. So one-to-one support, super, super important. Consistency of care provider, definitely best practice. So unique and interesting ways we've done this in our community, because that's all I have to go off of over the years, is assigning one POP worker to our high needs organization, and having that POP worker go to that high needs organization, that peer-based organization, where many people who are using substances hang out and they're comfortable there. So it's about the POP worker going to a place they're not comfortable instead of the participants of that particular support program going to the POP program. So finding places where people are already comfortable and going to them if possible. Outreach obviously is a really important piece. I think it's always shocking to stakeholders, policy creators, that not tons of our POP programs in BC do tons of outreach. The main thing is group work in the office. You come to the office, you come to the group, We might do a follow-up visit when a baby's born, but if we go back in time, it just isn't the authentic original intention of pregnancy outreach, which is going out in the street with your runners on. So for example, we call them in-reach workers in our Healthy Care Pregnancy Program. They do not have an office or a desk. It is not required. I do not need an office space. This person should have a backpack, be working out of their car, be working out of community organizations where pregnant people already are. When I was pregnant with Sadie, with my first daughter, and I was staying in a single room occupancy hotel and using, if I did not show up to Sheway, so that's our drop-in CPNP program in Vancouver, the street outreach nurse would come to your hotel room, knock on the door, who was part of the program, and say, oh, Heather, I just haven't seen you for a couple days. I would be using. And she'd be like, can I just come in and like do your blood pressure and listen to the baby? And I would be like, I'm using. So my drug of choice was crack. So I would be smoking crack, and she would be using the Doppler to check the heart rate of the baby and to check my blood pressure right in my hotel room. That in my head is what when we talk about pregnancy outreach, that's what I see in my head. And for some of our programs, we've moved so far away from that. That's the person we're missing though. And for me, that's sad, right? So we don't know who we're missing until we're out working and engaging in the street. Our numbers may be good, but are we reaching our actual target or most vulnerable population? Always a question to ask ourselves. On-demand visits. So always encouraging programs here in BC to make sure that we have space. So let's say we're doing lots of group work. Let's say there's barriers to doing outreach, fine. But do we have space in our schedule every day for on-demand visits for our most marginalized then? I've witnessed before a mom enter an organization. She was postpartum about a week. She had lost custody of her baby in the hospital. She was asking for food vouchers, likely for cigarettes, fine, whatever, I don't care. She was accessing the program. And she was turned away at the door because she didn't have an appointment and given an appointment. So knowing that people, when they lose custody of their baby, that's our highest vulnerability for fatal overdose in today's toxic drug supply environment. We need to have flexibility and room to do on-demand visits built into our daily schedules if we're not going out in the street and doing true outreach, so that we can meet people where they're at and really match our professional goals to a participant's needs, but also their own goals. So that person who had just lost custody of their baby was very obviously heavily using and maybe needed some food or some cigarettes. It is amazing in my mind that they came back to a pregnancy outreach program, because I assume that embarrassment and shame would stop me from doing that. It's amazing they walked in the door. Like, amazing, right? We don't want to miss those opportunities, because really, if we talk about a population too who's in their childbearing years, sometimes we are likely to have a subsequent pregnancy, like we talked about before, very soon. So we want to be keeping the door open. We want to be encouraging people. We want to provide healing support in hopes of reunification or some sort of contact or attachment with a baby. There's such a missed opportunity there if we aren't providing some sort of on-demand support as available. Of course, it's not always going to be possible, but we want to be thinking about that as we set up our programs and our scheduling. Groups we've already talked about, and repeat offers. This can be a really important one, especially sometimes I do training for here in my health authority. We call it Healthy from the Start. So you register your pregnancy in BC in every health authority, and you talk to a nurse as early as possible in pregnancy. They do a screening and they make referrals. So we talk lots about repeat offers. So when we go down a checklist of things we've offered someone, whether it's in BC here, we do a lot of like supporting people to voluntarily engage with the ministry, for example. Or we're offering people a referral to detox, or we're offering people a referral to a bed-based program. Often people will offer once, that person says no, and they'll say, well, they don't want to go. Well, they don't want to go today, or they're choosing not to go today, but it doesn't mean we shouldn't be repeating those offers, not in an annoying way, but when the opportunity presents itself again, we should be repeating offers. An example I always have for me is I was accessing She-Waste. So that's, you go there 5 days a week. You eat, you see a doctor, you access donations, you see Geo, whatever that looks like. You can go there 5 days a week to eat, because eventually, even if you're using stimulants, eventually you get hungry in pregnancy. I very specifically remember getting hungry at some point. So I would go upstairs and see, it would either be Ron, Georgia, or Sarah Payne working in the clinic. And before you could eat, you had to go see the doctor. Gio was really good at like, yeah, you can have lunch or access the food bank, but you're just going to go upstairs and see Ron first. Okay, fine. But we had a good report, right? So it was like, okay, fine. So go upstairs, see them, and every single day I would be offered a bed at FER. Do you want to go to FER? And that's the hospital unit where you could go live for your entire pregnancy in hopes to reduce or abstain from substances. It didn't require abstinence, but it required not using on the unit. And every day I would say no. And this went on for many months. And then I would start saying things like, yeah, okay, I'll go today, but I need to go get some clothes. And I would leave and I would not come back. Or I would say, yeah, I'll go, but first I need to go do this and take care of it, my partner or whatever. And I would never come back. But those repeated offers happened up to 5 days a week, over and over and over again. And it was just a normal part of our conversation. And there was never a threat when I said no. So it wasn't like, okay, well, you're not going to go today, but it's getting close, like we're running out of time. It was never that. It was, okay, well, when you're ready, we'll see if we can get you a bed. So there was always strengths-based support. There was never threats. There was never, I was never put down for saying no. And that's definitely the reason I kept re-engaging, right? So if you had those experiences, those negative experiences from declining a service, you probably wouldn't return to a service, right? So eventually one day Sarah was working and she was like, Heather, do you want to go to FER? And I was like, sure. I was like really pregnant by now. And I was like, sure, but I got to go get some clothes. And she's like, no, I got a bag of clothes for you a couple of weeks ago. They're right here. Let's go down and get in the van. And we went downstairs and they drove me to FER Square and I was there within like 20 minutes. And if I think back to that now, like how crazy. So they had it always built in to do on demand, to meet people where they're at, and they do not miss the window of opportunity. I said yes, and I had a partial excuse, but she did not miss the window of opportunity. It was like clothes wasn't a problem, and I was at FER within 20 minutes. And that definitely changed the entire direction of my life and why I'm sitting with you here today. Sometimes you'll hear people talk about like, oh, they're not ready yet. That's often, and I don't even think there's a negative connotation to saying that. However, my perception or my experience tells me that it is about so much more than being ready. For me, when I see different points in my life where my life changed for the better or the worse, let's just talk about the better. Stars actually had to align. I had to be in the right place. I had to have the right professional, the right organization, the right opportunity. The weather probably had to be right. My drug supply had to be right, whether that was out or I was taking some with me. Stars actually align for people's lives to change. It is not, we need to stop putting it solely on a pregnant person who's not ready. There are so many other factors, and all of us are one of those factors. So we also need to be ready to provide the right support. I hope that makes sense. So repeat offers are great without being annoying, of course. You just got to find that balance. Nutrition support, so awesome. All the advantages of nutrition. I think the example I love to talk about is, for me, and I've seen it with many other people, we know I've had 2 pregnancies. You could tell that my first daughter was shorter than my second, for sure. We're not short people in our family. My first daughter, I experienced much more violence, experienced much more sex trade, experienced way less food. So I had many more barriers. And Sadie was, at the time it was intrauterine growth retardation. Now it's called intrauterine growth restriction. And there's even a new terminology coming out now. So with that, that's not a baby who is small for dates. That's not a baby who is small, which would be like, let's say I see a family and mom and dad are small. Both partners are small. That's a baby who's small. That seems normal. Intrauterine growth restriction is actually about the lack of nutrients and oxygen getting to the baby through the umbilical cord. So we see a lot of that with stimulant use because it's a vasoconstrictor. So my first daughter, I was using I would say just as much as my second daughter, maybe a little bit more, but my nutrition status was definitely down. I was tiny at the time. I didn't even know I was pregnant when I was over 4 months pregnant. Couldn't tell, couldn't see. I was tiny, tiny, tiny. But she also ended up being very tiny. So likely she was over 36 or 37 weeks when she was born. And she was 5 pounds, 2 ounces. And now she just continues to be short, right? So she has my sarcasm. She jokes about it now, which is great. Our family's very open and realistic about our history. But then you look at Celine, I was housed. I had way more food. I had a kitchen. So when I talk about housing, I talk about things like refrigerators and kitchens and stoves and microwaves, because there was a pregnancy I didn't have those things. I was connected to a program giving me vouchers, less violence. I wouldn't say no violence, but less violence and less sex trade. So I was in Kamloops for my second pregnancy, and she was born over 8 pounds. And right, so we really want to look at how nutrition affects people, and I'll even go on a limb and say it is a huge success. Even if someone never reduces the amount of substances they're using, if we improve their nutrition status, we will contribute to better outcomes for both the pregnant person and the baby. So if the only thing you do is provide food, good food boxes, hot meals, snacks in your car when you're doing outreach, a juice box, everything we're doing shouldn't be engaging around nutrition, especially when we're talking about people using substances who tend to be malnourished, which obviously affects the fetus. But if that's the only thing you do, I want you to recognize that as success, because we will absolutely impact the outcomes, not only for the baby, but for the parent as well. It's also, if we want to think about, let's say someone's even using and they're not reducing harm, they're not reducing use, or they're not planning on abstaining, our minds work better when we're well nourished. So how do we expect people to make all of these changes, go to detox, go to treatment, find housing, leave your partner, stop the sex trade, start testing your drugs? How do we expect people to do that who don't even have food on board, right? And I'm sure we can all think of it. Like, I've been up since, 4 today because I'm 40 and hormonal or something. And, I haven't had a snack yet today. Like, eventually I will start not thinking clearly. I might be a little bit snappy at my staff. And yet, if we look at someone who's using stimulants like myself, I didn't eat for 3 or 4 days at a time. And then the expectations we have of people, right? So that role of nutrition support is way more important than most people think. And I'm assuming many of you are being like, yes, I totally understand. And I love that. I just want you to remember how important your role is specifically around nutrition for all families and all people. In the hospital, I love having this discussion, especially when we have management on board, because often in the hospital, there's this idea that I've worked on a unit where we lock the fridge so no one steals the sandwiches, and how insane that is. So if a marginalized person needs to eat where we are, we need to be feeding people. We need to be filling up their backpacks with all of the foods. Really important. I'm just going to go over a couple tool cards, knowing we're at 8:13. Sydney, do you feel like we need to leave time for questions, or do you want me to go right to 8:30?
Maybe even just a couple minutes, like 5 minutes. Yeah.
Yep. So I'll go into a couple tools that we find really helpful in our POP programs and our CPNPs, our CAPCs. I'm sorry, I should use CAPC more often. So we have the same people in training as well. So safety planning, often perinatal professionals, frontline workers will say, well, safety planning is MCFD's job or a delegated agency's job. And safety planning for child protection is MCFT's job. Safety planning for all families and pregnant people is all of our jobs. So MCFD or child welfare, love to see that somebody has already started thinking about safety planning And safety planning really is universal for all of our families. So these tool cards used to actually be on a piece of paper. There was 6 to a piece of paper, and we just printed them off when we started this PSU training. Now it's this really beautiful card. I think now it has the Pregnancy Hub logo. So some organizations make this card. I don't care, make them all day long. Some organizations purchase them for us, and that goes to support our Pregnancy Hub. So however you create a card and use a card, I don't care, as long as you're doing safety planning with all of your families, which is one of our recommendations. So what was great about this card, the change that created from our first cohort of people who went through our PSU training, is that this used to say, people I trust to care for my children if I use substances and cannot parent safely. What it changed to, and it was such like an aha moment for me, and I love that, is it should just say, if I cannot parent safely. Because how many times do all of our families go through things they can't parent safely, whether that is postpartum depression, mental health, depression, violence in the home, not taking care of myself, not sleeping, whatever that looks like. So this is a card we really encourage people to use. The point of the cards always is a conversation starter for people who are not necessarily super comfortable with having these conversations. It's a great reminder, and it's also something your participant takes home. So if I'm a professional, I'm not documenting the name and phone number of your safety people. I want you to write them down, and I want to know that you have 2 people. This safety plan translates to my work as a frontline worker. It translates to my work when I train people. It also translates to my work in detox and in labor and delivery and maternity discharge planning. As an RN, as a perinatal professional, just as a human being, when I am caring for you in whatever context, I want to know that you have 2 people you can call to help you with your kids. This is a great conversation starter, because I say, oh, do you have 2 people who can help you if you can't parent safely? If blah, 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 give examples. And they say, one example that people will say is like, oh, my MCFD social worker. Instantly, I know we're lacking natural supports, and I better be referring to peer support programs. Or they'll say, oh, I have a huge, what's a classic, like, Italian family, and everyone's always around, and my mom's not going to leave me alone, blah, blah, blah. I know not to worry about you. Fantastic. That's great. But what I want to do with this tool card is I want to catch the people who maybe are slipping through the cracks and nobody knows that they don't have natural supports, and it happens all the time. We discharge people with a baby all the time, not knowing whether they have 2 people they can call or not. So it's a simple fix to that. It's a simple solution. The earlier we start in pregnancy, of course, the earlier we can add interventions. Oh, you don't have natural supports. I mean, groups are great. And this of course should be going with every family. So that's that universal precaution or universal education again. Next one is relapse prevention plan. You can go online and you can find all sorts of really complicated relapse prevention plan. This is not a universal tool card. This is very specific to people who have self-disclosed that they use substances and who say that they are trying to remain abstinent. So this is not for people who are not in a place to aim for abstinence or harm reduction or are choosing not to. This is specifically for people who are trying to attain abstinence from substances. Really simple way. Again, MCFD would make this very more complex, more complicated. That's fine. That's not even on my radar of things to worry about, because that's MCFD's job. It's not my job. My job as your nurse, my job as your frontline worker, is to make sure that if you are struggling with abstinence from substances, that I'm doing something to support you. Really, really simple way is to support you. So this one looks cooler now. And then on the back, it's got the written stuff. Again, this is for someone to take home with them, post it on their fridge. And people will say like, oh, but Heather, everyone loves apps and stuff now. If you yourself are a person who's ever struggled with substance use and getting abstinent, and you've experienced a craving for a substance, you know that an app is not within reach. I need to be seeing this every day. I need to be walking past this. I need this physically, like we need to go old school on these tools. We need to physically have them in our house, right? It's kind of like with period of purple crying. Do you have period of purple crying? Don't shake? Okay, so it's kind of like the idea when we work in the hospital and we hand out, reminders. You want to have families, partners, caregivers seeing the period of purple crying examples in their house. You don't want it just on an app. So a really great way to start a conversation if you're not comfortable talking about relapse prevention planning is to use this tool. 3 things, that one says 2, on this card it says 3, activities I can do if I think about using. What's important to know about cravings, obsession, and compulsion to use substances is that likely when you ask someone this question, they're going to say, well, I'm going to have a bath, or I'm going to light a candle, or I'm going to play some soft music. If you really struggle with substance use, none of those things are going to interrupt what's already happening in your brain. So when we learn about neurobiology of how our brain changes when we're using something like stimulants, it actually creates highways that are very, very fast and very good at getting us from a thought of using to using. Those pathways need to be shut down for about 2 years to create new pathways to other sources of joy. And I talk about that more in my training. It's super interesting how our brain is like plastic and it changes using substances versus being abstinent. So if I have a craving, I need to do something. It needs to be physical. Some people, you'll see lots of people in early recovery going to the gym, running, doing active things, hiking, whatever that is. For me, the best advice I ever got when I was in early recovery was to read recovery literature out loud in my house. So you can do that any time of day. My cravings happen at night after my kids go to bed. And what it does is I cannot talk out loud. It's just great that it's about recovery. So I'll read like a 12-step book or something out loud. I cannot physically do that and think about using at the same time. It actually interrupts your brain. So we want to be having these conversations and we want to go beyond the I'm going to have a bubble bath to interrupt my craving to use heroin, because it's not going to work. That knowledge is really important for us to share, and it works for many people to think about what can we do. And then I also want to know, yes, you have 2 people for your safety plan that are going to help you with your kids, but I also want to know as you're one of your care providers in your team is, do you have 2 people that you can call if you think about using or relapsing? So I want you to know that in your head. I don't need to know who those people are. You can write it down. You can take this tool card home. I just want to know that you've thought about it, because what that does is when people relapse, huge sense of shame, right? For me, I relapsed. I was about 5 months postpartum. I was exclusively breastfeeding. I couldn't tell, there was no one to tell. Everyone was excited I was clean. Everyone was excited I had this baby. It was lots of like, yay, everything's cool. No one had ever talked to me about what if you use. Everyone thought the baby was the solution. I had no one to tell. I had no one to call. So I continued to relapse and use as a result of that shame. If I had thought, if someone had talked to me about like, who's your safe person? And it needs to be, like, I don't need you to tell me if you relapse. As a nurse, again, I'm not your MCFD worker. I need to know that you have someone that you can disclose that to, that you feel safe talking to. I don't care if it's a counselor, a public health nurse, your best friend, your old friend, your aunt, your cool aunt, whatever that is. I just want to know that you have that person so that we aren't getting into a spiral of guilt and shame that's leading to way more use going on for many years. If you've ever had anyone in your life who's used, I know for me, a simple relapse on like a beer turns into 5 years of using for me instantly. And I still know that about myself today at 16 years abstinent. I know if I have a beverage of alcohol, I immediately want cocaine. I can feel it in my stomach as I say it out loud. It's just the way I'm made up. So really being able to get comfortable in these short conversations. If you've ever done brief intervention training, we're not looking for people to be experts, to do big books, to create complex things. We've created tool cards that are supposed to be easy to use, increase your comfort, and directly impact outcomes for families. And we don't have to be doing, this can take you literally less than 3 minutes with a family, and we all have 3 minutes. I hope. Sydney, think I'm going to stop there.
Let me find my hello. Heather. I feel on the edge of my seat, and I feel us virtually all just really, here and with you, and just soaking up all your sharing. And so we do have a couple of minutes for folks. If there is a question that you have for Heather, feel free to pop it in the chat, and maybe while you're thinking about that, I can tell you, Heather, I mean, there's of course lots of gratitude in the chat, and there has been throughout your whole presentation. And there has been lots of reflection on our comment board, and
awesome.
Things like nice to hear from someone who has worked with CPNP in another province and knows their stuff, which is very cool. And
some of my CPNPs might disagree with you. Not everyone agrees with Heather.
It's a great combination, empowering presentation on so many levels, especially your comment around when we make a blip in our language, right? That yes, apologize, but move on, right?
Yes, don't turn into the victim.
That's right. For then the person who we've made the mistake to start taking care of us.
Yes, and it happens we've all done it. I've done it too, right?
We feel mortified that we've made the mistake.
When I learned about that, I was like, oh, I need to immediately stop doing that.
Right. So that's and so this is amongst a lot of comments similarly. So, and an acknowledgement that hard copies of the resources are effective and helpful, and then apps, people are, made a comment.
Yes.
So, yeah, I'm not seeing any questions coming up in the chat, but if there is, also feel free to unmute yourself if you do want to as well. Again, but lots of thank yous that are happening. I want to, as you mentioned, we are lucky that you are joining us again next month for 2 full days of training, and that training is full, right? If my memory is, and that there's,
I think you're correct. Yep. I think it's on. So the wait list is open on it, which is nice.
Okay.
And I guess I'll throw that link into the chat, because I think you wanted to keep a record of the wait list, Sid.
Yeah, and I will add the link to sign up also to my follow-up email.
Okay, you do that. I won't do it. Perfect.
Yeah. So, and I'm sure the folks who are, registered, who are here today are, getting extra excited for those, spending those 2 days.
Well, and I hope, always my thing is 2 days on Zoom sounds like a lot. It sounds like a lot for me too, but I just want to encourage you, there will be a lot more discussion, because we have such a nice small group. That's why we keep it to 25, is so that there's way more discussion, lots of breaks, lots of opportunities to get away from your desk, because I know it is 2 very long days.
Excellent. Thanks for that. And I put a little earlier our session survey in the chat, and I'm just popping it in there again. We do appreciate your comments and feedbacks on all of our sessions. Helps us to, as we're planning upcoming events in our network, to kind of know what you're thinking and what topics you're interested in, and your feedback on this. And so we do have our coffee cards to give away. We have 3 $20 coffee cards, just a little bit of fun for those who are here. So unless you had anything else you wanted to say, Heather, maybe I have a few questions from your presentation that I'll ask, and we'll, the first person who sort of gets it in the chat. Maybe Heather, if you're willing, the first person on your chat, or do you see the chat? Okay, so if you, because sometimes it can be different, right? It can show, the order can show up differently. So maybe it's the first person on your chat screen.
Okay.
Who answers the question. So the first one that I have is, okay, you talked about, you identified who perhaps might be considered the most important person in an organization or program. And in terms of, connecting with folks. And I do see some answers coming up there.
Yeah. Lucy got it.
Lucy. Excellent, Lucy. I thought that was such a important thing to say. And perhaps I also had a heart moment since I was a receptionist front desk person at an organization supporting child survivors of sexual abuse.
So important.
And I felt empowered by that in the organization, and sort of know what that feels like. So Lucy, congratulations. I don't have your full name or email, so all of the winners, please send me an email, identifying yourself as a coffee card winner, and we'll hook you up with that. Okay, the second one, you talked about language a lot, and again, just such important information. So you used a term, and I'll say person blank language. Person blank, what is the blank? And I see lots of people are getting it. They're
Nancy.
Nancy is her last name? There's a few Nancy.
Nancy Tolok.
Nancy T.
Forgive me if I'm saying it wrong.
Oh, congratulations.
So person
Nancy.
first language. I see some people got neutral language, which is awesome too. That was on my slide for sure.
Totally. And you talked about, you've been sharing about safety plans, and you wanted to know at least that people had how many supports that they could reach out to.
It's so funny because when people answer the chat, so MJ is the first person. When people answer the chat, it goes like it goes up, so you can't stop it to go see the first person.
That's right. Catching the first one.
MJ got it though.
MJ, congratulations. And again, MJ, please reach out to me and let me know your name and email address, and we will hook you up with those coffee cards. Thanks to everyone who joined us here in person. Great folks, and thanks for your reflections on our comment board. And I look forward to hearing your thoughts on the survey, and circling back to thank you to Heather for maybe getting up a little extra early. Both of us here are on Pacific Standard Time, so I'm with you now. For us, it's just got light out recently. Anyway, your time and your presence and your wisdom has been very valuable, and I've really appreciated that you've been able to join us.
Thanks, Sydney. And I will take some time during the break just to go back and read all the chat messages before I leave, because I always appreciate that.
Oh, welcome. You're welcome to stay along as long as you're able. And I'm going to stop our recording. Where is it? There we go.